Thank you so much for joining our third annual Community Health and Advocacy Conference, both in person and we have folks virtually on Zoom. For those of you that don't know me, my name is Sarah Ventry. I'm a general pediatrician with UBMD Pediatrics and assistant clinical faculty for the Jacobs School of Medicine. 2 years ago, we started this conference as a way to get healthcare folks and community-based organizations together in the same room discussing topics that are relevant to our community. And this year, I'm excited to say that we have been able to expand from just the pediatrics department to all departments, all medical departments, from neurology to internal medicine to OBGYN and psychiatry and surgery. So really glad to have this being a really broad group of medical folks here today, as well as a really broad range of community-based organizations. So thank you. As you know, this year, the focus of the conference is housing and neighborhood health. During the keynote, you will hear about the intersection of housing and health from Kay Elise Green from Boston University, who I will introduce shortly, followed by a summary of neighborhood planning and development framework for Buffalo's East Side from Dr. Henry Lewis Taylor. I also want to take a moment to recognize that while we are here today talking about home and neighborhood health, it's important to note that where we are currently sitting was previously home and traditional territory of the indigenous Haudenosaunee people. And even more recently, the building of this medical campus has resulted in some unintended consequences, including displacement of Buffalo residents due to rising rental costs. So I think it's just important to recognize for the medical community and to reflect on this as we move forward in our discussions of strategies and solutions for neighborhood health. Before I introduce the speaker, I also want to say thank you to our sponsors for today's event. Thank you to the Department of Pediatrics and specifically the Dr. Irving Snow Fund. Dr. Irving Snow started this fund at the University of Buffalo in July 1931. Dr. Snow taught pediatrics at the medical school and created this fund to support trainees, providers, and community education and lectures. I also want to thank the Children's Hospital Fund of Buffalo, the Children's Hospital Foundation, sorry. This is their third year supporting this conference, so thank you to them. The Office of Graduate Medical Education and the New York State Children's Environmental Health Centers. So now I'll introduce our keynote speaker, our first keynote speaker, Kay Elise Green, who is an MD, JD candidate at Boston University of Medicine and Boston School of Law. Her career and educational interests are anchored in 3 areas: urban, children and families, intersectional, interdisciplinary healthcare, and upstream drivers of health inequities. These passions fueled a unique educational and professional journey ranging from financial project management to research on the impact of racialized medical education, curriculum, and policy. Ms. Green received a BS in psychology and a master's in interdisciplinary studies with a dual concentration in public health and urban education from University of Central Florida, UCF. In 2022, she was honored as one of UCF's 30 under 30. Since beginning at Boston University School of Medicine, Ms. Green was privileged to serve as the inaugural Diversity and Inclusion Fellow for Boston University School of Medicine with a joint appointment as a visiting fellow at BU's Institute of Health Systems, Innovation and Policy. In addition, she has published multiple papers on the intersection of medicine and social determinants of health. In 2021, she transitioned to Boston University School of Law. Since joining school, she has become staff editor of the American Journal of Law and Medicine, the Women's Law Association president, intern for Honorable Sorkin at the District Court of Massachusetts, and Rappaport Public Policy Fellow, who interned in Massachusetts Attorney General Office Healthcare Division. In 2023, she completed her second year of law school, interning, exploring different aspects of the law and supporting human trafficking victims through a tenuous visa process. Now she has transitioned back to Boston Medical School to complete the remainder of her dual doctorate program in this year seven of 7. Thank you so much to Ms. Green for joining us today from Boston.
Hi, everyone. While we're getting slides, can everyone hear me in the back?
Wonderful. I whisper at baseline, so just like wave if I begin to go quiet. Thank you so much for having me. I'm truly tickled to get to have this conversation with you all. I hope it is a conversation that is something that enriches all of us, really starting and thinking about how housing and home really impacts our health and understanding of who we are, and how all the other factors that have created this here have created the reality that we're working through, and finding some potential solutions for that. So we're gonna just finalize getting some tech together and we'll be ready to go. If my notes don't pop up, that's just fine. That's just fine. I really look at it. Wonderful. Alrighty. I'll send it up next. Oh. Not showing the notes. Not the- not the same as-
Apologies, there's always technological difficulties, no matter what we do ahead of time. So look, okay, we got it. Great.
Wonderful. Alrighty, everyone. So the intersection of housing and health. Just wanna, oh, wrong button. Okay. Disclosures and acknowledgements. I have nothing to disclose, but I would like to say my two mentors, Dr. Thea James and Dr. Megan Sandell, have shaped who I am. They are the reason I think about things like this. They are probably actually the reason why I have this opportunity, and just want to honor them and the advocacy they've taught me, the wisdom they've given me, and the practical help of the slides they've shared with me for today. So we're going to start in a potentially different place, and we're going to run you through this agenda. What is the difference between home and housing? How has the history of housing discrimination in America created the realities we're seeing today? What is the magnitude of the issue and the impact? And what are strategies for change? Because I know all of you are here not just to lament on the reality we have before us, but to find ways to move forward and create a different future. So home, this is my grandmother and me. And I want us to start here. And I want to acknowledge that some people's home is not a place you would ever want to go back to. Home for some is full of abuse and harm. And so I want us to just honor that reality, but think about, for those who that is true for, what could home have been? What do you wish home to be? And I want us all just take a moment to center in home, because I think as advocates, we get to the place and we're like, we're here for housing. And housing is like a great policy term. It like sounds really good in the paper. It's a good thing to talk about, but we're actually not here for housing. The physical structure is something, but it's not the thing we actually are doing this for. We are doing it to give people the opportunity to have home. And so I just want you all, as we begin to navigate this journey together, to remember our why, which is about home. And for me, that knee that I am on is the safest place I could ever be. That knee is full of love. That knee has taught me how to push forward. A grandmother's love spurs you forward in ways that most other loves can never do. That is what home looks like to me. And yes, it happened in a building that there was a kitchen and bedrooms in, but that was what the stability gave me to become this person. And that's what we are pushing for people. And from a woman who knows always the right words to say, let's look at Maya Angelou and what she explains home to be. The ache for a home lives in all of us, the safe place we can go as we are and not be questioned. The stability and the foundation of someone's existence often begins at home. And that is what we are doing as advocates, to bring houses to people so they have the opportunity to create a home. So from here, we're going to talk about history. Inequity by design. I know that this is a community and a group that has mixed backgrounds. So we have folks from the US, we have folks who are not from the US, we have medical, and we have our community members. And I want us to all sort of get a baseline of how did we arrive here? And why is the inequity by design important? And I want you to hold that by design in mind as we move towards the end of our presentation, because if something is designed to harm, it can be redesigned to help. We are not stuck with the reality we've been given. There's hard work before us to change the reality that we have. So I love the law, and you're going to just travel with me for a little personal passion here and also explain why housing rights and property rights are incredibly important, specifically in the American context. So Shelley versus Kramer, this is a US Supreme Court case that struck down racial covenants. And this is from the Supreme Court opinion, and it says equality and the enjoyment of property rights is an essential precondition to the realization of other basic civil rights and liberties. And why that is important is in the US Constitution, owning property is the entrance into the ability to participate in society. So if you did not own property, if you did not have a house or a home, you could not engage. And so when we think about the conversation about who was denied property rights, we can think about to the Civil War of 40 acres and a mule was a promise that was never kept. And the reason why that is both contextually important is by giving them property, it was actually a symbolic act to say, you are now a full citizen. We have given you something that we have deemed important from the beginning of this country. And the restriction of that is not just a conversation about race, it is a sordid commentary about how we value and who we deem to be allowed to be citizens and what citizenship looks like in the fullness as we restrict those who have access to houses and property rights. So understanding that foundational context is actually much bigger to deny someone a home here in the US, because it actually questions, are they American in the full respect of the conversation? So from here, we're going to go back to redlining. This is probably a concept, if you're here at a housing conference, you know a lot about, so we'll move through quickly. But it's from the Holcomb redlining map, and which was part of the Federal Housing Association, their map on how they wanted to do value. But I think something that I want to change in your mind is recognizing that this is not just a question of financial risk. This was not just a question that just happened to be tied to race, but it was foundationally understood that the presence of or the proximity to a non-white person was seen as an increased financial risk. So the closer someone lived to me, the higher likely it was a less financially stable opportunity and thus became less valuable land. Stability is equivalent to value in finances. The more stable the fund, the more value it has. Risky funds become something that have questionable value. My being was seen as a risk. And that's why I was in a red neighborhood of less value. This is a map of Buffalo. This is your community. And I want you to take a good look. We'll circle back to this map and we see where the red areas are, which is hazardous. We have yellow, which is definitely declining. Blue, still desirable, and green is best. Red and yellow were always confined to immigrant communities, predominantly Black communities, who were seen as less valuable and more risky people, and thus creating this reality. So I know we're bringing this connection of race, value, housing, but we're at a medical conference. So how does this all come together? So we're going to go back in history a little bit and understanding how race is foundational to our understanding of medicine. And also wanting to bring up something that's been very relevant for this audience is we think about EGFR, PFTs, race-based medicine is a very large conversation right now. Why are we now just thinking to change those things? And where did those things come from? What's the foundation of that understanding? So I'm gonna show you a bundle of things that are gonna be offensive at baseline. They're not me, they are history, and history, it is honest truth. I think that truth is rare, honesty is rarely becoming to anyone. And it surely is that way for the medical community. So this picture. This is a picture from the early 1800s, Darwin's contemporaries after him thinking about how do we move forward for all the pre-med, for all the medical students, you remember the pre-med days of the biological trees of kingdoms and families and the sort of the sword memories there. And we think about this picture. And why this picture matters is the foundation of medicine was built on the fact that different races were different species of beings. I'm not slightly different because there's more melanin in my skin or where I come from. It's equivalent to saying a golden retriever and a Rottweiler are different species of an animal. They are not the same. And thus, if you are not the same and you're a different species, I can say one is good for something and one is not good for something else. All of us can probably agree. A golden retriever is no guard dog. Rottweiler is. Golden retriever like, oh, hello, human. You seem so kind. Do you want to come in? Like, that's the golden retriever energy. We love them for that. But they are a different species. They would never be employed as someone who is a guard dog because they just don't have guard dog energy. That's not who they are. Their species is not made for that. As opposed to a Rottweiler, which has often been trained for protection and aggression, that is what that species is made for. So let's think about pulmonary function tests, spirometry. We're going to loop this theory all the way forward. So spirometry was created to prove that I was better use in outdoor field work, thus my lung capacity was different. I used oxygen in a different way than a white colleague. They're proving that I am a golden retriever as opposed to a Rottweiler and better served in a different purpose. And that is because the foundation of medicine created a racial hierarchy to say the species of whiteness is the ideal and best species, and everything below that is not actually a human being. It is something drastically different. We're going to circle back to a law analogy if this is not convincing enough. In the Constitution, Black men, men only, we can take that up as a separate conversation, were seen as 3/5 of a human. They were counted in the population as 3/5. There's a full denial of their full humanity. And that's thus why you can be lynched and made to work and do all different things, because if you're not fully human, the things that I would do to my family do not matter to you. This is the foundation of medicine and where medicine began. As you can see, above the buffalo is an indigenous person, because that seems to be the most common line that they are associated. So holding this in memory, how does this play out in life? Some of you may be very familiar with the Loving case. This is my area of legal research, and I thought I should bring it to this community. So we often think about interracial marriage. As you see there in the photo, Mr. Loving is a white man, and Mrs. Loving is an African-American and indigenous woman. And they wanted to get married. And so in Virginia at the time, it was against the law to be interracially married. And so they went to Washington, D.C., and they got married where there's no interracial laws. But what you probably didn't know, that most of us, and I didn't know as well, is the law that Mr. and Mrs. Loving broke is a miscegenation law. Miscegenation comes from two Latin words, miscere, to mix, genus, species. They broke a law of mixing of species. If you look on the right of that photo, that is the health bulletin published by a medical doctor about the new Virginia law to preserve racial integrity, to preserve the purity of the species. So the marriage of Mr. and Mrs. Loving is equivalent to crossbreeding two species. The term of the day that was used around the Lovings and in many states as these laws function was the term of mongrelization. In common discourse, in public and political speeches, that's what they equivalated interracial marriage to be. And just so we all understand sort of the bewildering component of this and how it played across the country, it was only banned in certain states for certain races. So if we went to the Pacific Northwest, there was no ban against Black and white marriage, it was a ban against indigenous and white, because that was the issue and the people they had concern with. In different areas, it was different things, because race only becomes relevant when you think it's relevant for preserving power. But when we understand that this case, which took place 1924, my parents were born in the 1950s. This is not history from distant past. This is very relevant to us, and this is why the foundation of medicine comes in racial hierarchy. And so you see that played forward into redlining, and it's not a surprise how we end up of categorizing people to deserve less than and see disparities long term. Just to reinforce it a little bit more, I'm going to read you quotes from colleagues from back in the day. So at the American Journal of Medicine, it says, on the biological phase, there is an authority for conclusion that the crossing of the primary races leads gradually to the regression and eventual extinction of the resultant type unless it's fortified by reunion to the parent stock. Dr. Wright Engel, professor of physiology at the University of Chicago, says the biological experiment of interbreeding, let's understand, not procreation, not family, not children, but interbreeding cannot be done without risk to civilization. These are quotes in published papers. These are not just quotes in published papers. These are quotes that were used by the state of Virginia at the Supreme Court to prove to them why they were scientifically right. The Lovings had no scientific citations in their paper because they were talking about humanity. The state of Virginia's entire backing, I've read both briefs cover to cover, what was sent to the Supreme Court in the opinion back. It is full of scientific information on why this was a compromise of humanity and our civilization based on a scientific understanding instead of one that looked at the dignity of the person before. So this is where we are coming from. This is where the understanding of red line neighborhoods is growing out of. It's this background. So let's pivot forward. We have redlining ends. It's essentially banned by the authorities, and it actually curiously has nothing to do with the Fair Housing Act. It was banned before that, small piece of history. It was done because they wanted to say, this has nothing to do with race. This is actually a financial investment. This neighborhood is more risky. But then comes a schema of predatory inclusion. And I just wanted to say it's always maybe risky, if we're using the term, to talk about something that the author of that is in the room, or more importantly, the father of that person is in the room. So Dr. Taylor's brilliant daughter has a book called Race for Profit, and this is her theory. So predatory inclusion, it is what happens after redlining. It's what preserves our red line neighborhoods in a way that's not legally enforceable, because we're not saying we're only allowed to be there because you're causing more risk. It's saying, this is just what's happening, and we have all these different manners to keep people in the same neighborhood. So the scheme of predatory inclusion, this is my definition of the other Dr. Taylor's work, is the strategic implementation of a colorblind federal and local policies allowed for unprincipled partnerships between realtors, lenders, and laissez-faire government officials who took advantage of minoritized communities, reinforcing racial segregation and creating a revolving door of generational poverty. You'll see in the photo here, real estate exploitation produces ghettos. This picture of understanding how are we forcing people to remain to produce these neighborhoods that have drastically disparate outcomes. It's by exploitation, which fits under the scheme of predatory inclusion, which is what propagates what we have seen in redline neighborhoods all the way forward to today. So where do we go from here with this history? I want to give just an example of how this looks like. So we have Buffalo, the redlining map you saw before, on the left, and you see on the right, your highways are highlighted in yellow. The orange neighborhoods are places that have been shown for major displacement and housing. People are pushed out. What do you see that's there? If we look in the bottom right of both the photos on the right and on the left, those are red and yellow neighborhoods. If we look and see where highways, which we know cause pollution, remove people from their homes, give up green space, cause higher risk, those are through red and yellow neighborhoods. There's a big circle where there is no highways. And if we look, we see that is where blue and green neighborhoods are. This is the ramification of predatory inclusion, because anyone would say, I don't want a major highway running through my neighborhood. The house next to the major highway will always be worth less. So if we've created neighborhoods that are protected from that, their houses will always be more valuable. And if we've caused communities that cannot access those neighborhoods because of racial covenants or just generalized pushing out, we create places where they will never gain as much value on their home because of the practical environment that they are forced to live in. This map is equivalent, and it can be seen in not just Buffalo, Boston, and Massachusetts. It's truly just as bad around the country on how this schema continues to function and thus lock in the disparity that was created in the 20s. So if we were unaware or just really were like, but that was highways, does it really matter? This announcement press release from the Justice Department is from 2024. That $13.5 million were given for redlining cases. This is not the only settlement that they have done this year. Millions and millions of dollars are being pursued by the Department of Justice to give back money to the communities that have been denied fair lending to this day. And if you look to the right, that is an article from the New York Times, that Black owners face discrimination in appraisals. And I can say this for my own family. My parents used to live in a very large house on a lake in Florida. When they're getting ready to sell it, because it was now the two of them in this very large house, they said, they took down every family photo that was in our home. The only thing that remained that identified it to my family was my parents' wedding invitation. And my mother is Monica Elizabeth Ross. My father's Jeffrey Edward Green. Truly could be anyone if you're thinking racially. They got married in Jamaica, which is like fun, like destination wedding. My mother is actually Jamaican, so they were going home. But to the unknown eye, it's like, look at Mrs. Ross and Mr. Green. They went to Jamaica, had a great time. That's all they're thinking. And the reason why is this couple here, the wife of this couple is a lawyer, and she had her house with all their normal family photos set up, and they got an appraisal. And it was low, and she knew it was low. So she stripped the house of all of their family photos and had her husband, unbeknownst to them, be the person who showed the house. And there's no family photos, so they don't know that he's not married to someone who's white. At least 10 to 20% difference and increase in the family value. My parents did not show the house. We had a friend who was white show our home. They stripped it of all knowledge because when you have a house that's multiple millions of dollars, 10% is a large amount of money. And if they were going to lose 20% because their presence, solely their presence devalued the home, we were going to ask someone who recognized the situation we were in to change it. That happened last year. So recognizing that this is going on, this is our unfortunate reality. We have work to do, not just at finding homes and creating houses, but actually changing the culture underneath, that the scheme of predatory inclusion that is beginning in the 40s, 50s, and 60s shouldn't have as much power that I'm deciding where I'm going to live or I'm asking a white ally to show my home because I actually can't get the money for it. So now that we understand where we've come from, it's sort of a downer in the room as it should be. This is where we're starting from, and this is where we have the opportunity to move forward from. So what is the impact? I want you to think about impact in 3 ways: wealth, health, and community. Wealth equals health. If you have the money to afford to go to the doctors, if you have the money to afford things, you will be able to have the health you need. To the medical students in the room, you're going to hear a word that is said often, and I hope you begin, if not ever before, in this moment to take issue with: non-compliance. This person is non-compliant to their treatment plan. I want you to never take that as an answer. I want you to ask your attending, what do you mean by they're non-compliant? What is the issue with non-compliance? Because often people who are non-compliant is a mother who, yes, has hypertension, but whose child is hungry, and she would rather take the $20 to make sure her child has food than to buy the medication that she doesn't feel the longitudinal ramifications of coronary heart disease currently right now at 40 that we know is coming. But she knows her child is hungry today. So her non-compliance is not non-compliance, it's reasonable, phenomenal parenting and love. And that is why she can't afford the medication that you prescribe. So recognizing where non-compliance comes from is drastically important to the way we see and treat our patients, but also understanding the reality of their lives, that maybe we should do a better job of finding more reasonable price medications, or just figure out why her child is hungry in the first place and address that, because if she had the money to feed her child and get her medication, I'm sure that she would. And then lastly, we want to talk about community. Where we grow up, the bubble we grow up in changes who we are. I had that grandmother's love you saw at the beginning. I come from a family of athletes. I grew up in a place that we competed not to prove who we were, but because we wanted to see how far our bodies could go. That changed me. That changes how I show up to rooms. When I'm in the operating room, I feel like I'm on the athletic field. I love it, but it's a team-based endeavor that we're moving towards something. I don't mind alpha females because I've only known them. Our community shapes who we are for better and for worse. So let's think about how housing and health meet here. This is the big picture. This is our Maslow's hierarchy of needs. We're going to start at the bottom and move our way up with physiological needs, safety needs, belongingness and love needs, esteem and self-actualization. Housing is what creates the bottom 2 in many ways. A quote from my mentor, Dr. Thea James, is people cannot prioritize their health when they are prioritizing survival. We've proved this through history and science, through this pyramid here, and now we see the ramifications of that example I just told you about the mother. She's not going to give up the physiological need of her child to do something that will provide her longitudinally health, but in the moment, it is not something that is prioritizing her survival and the survival of those she's caring for. And so how does this become? How do we create disparities, and where do they come from? This is a structural understanding of health disparities. We have on the left, they are the inputs, they are the forces that move things forward to create the realities we see. I hope that through this, you will never think that what I'm seeing is actually what it is. What you're seeing is the consequence of what was and is maintained by the structures at play. The poverty is not just poverty on its own. It is a reality of how politics, economic systems, social hierarchy, specifically racial capitalism, has pushed forward and created certain groups of people who are impoverished based on their lack of agency created through the structures. And the inequality, again, created through the structures is what combines to create worse health outcomes. So the social determinants of health, we think of them as upstream drivers, and they are upstream to the health outcome. They are not upstream to society. Society is the top of the waterfall. That is what created the social determinants of health that now dictates our health outcomes. So when we're thinking of upstream, keep pulling back to gain the full picture of where you're going. And while we're not quite at what do we do about this, I want to just bring into the place and honor the reality that this is overwhelming. You're like, I can't go back to the 1900s. That's like not my journey. I wasn't there. I couldn't have impacted it. I am now here. And the reality of that is that's okay. Because you're now here. And if you didn't know this 10 minutes ago, now you do. And your work at any level is necessary, valued, and important. You can't do it all. You can do something. And so as we begin to engage with this conversation and figure out where this is, I want you to also begin to do that self-work for you and think, am I the person who is the direct patient partner? That I'm gonna say, okay, Mrs. Jones, I see that you can't get the medication. I now understand that your child doesn't have food. I'm gonna connect you to our food pantry. I'm gonna show you GoodRx, and we're gonna partner on that level because that is saving Mrs. Jones' life and her child, and that's valuable. Or are you the person who's upstream, changing policy and making national conversations around why medicine is so expensive? We need both. And whoever you are and whoever you decide to be and work, I want to say before someone doesn't say this to you, and most likely won't, thank you. Thank you for choosing to engage, because we need you wherever you decide to be on this spectrum. So let's think and bring it back into housing. I gave you a tour of the world up here. We're going to bring it to the conversation of today. These are the domains of housing. On the left in dark blue, we have access. And on the right in light blue, we have opportunity. I have in bold questions. And these are questions I want you to think about when you have a patient or a client who comes in and says, I have unstable housing. These are things that you can ask them. These are things you can ask yourself about where they live. So quality, is the physical home safe? Do we have mold? Do we have pests? Are things falling in? Let's understand, my housing is insecure. Is it because you have no running water or heat? What is the issue with the quality? Next is affordability. Will living here compromise my ability to take care of my well-being or take care of my family or those who are charged to me? Thinking about cost burden, thinking about paying more than 30% on your rent is to burden somebody with having a home. Let's think about opportunity, stability. Can you build a life here? Are we forcing you out? Are we putting buildings and highways, making it unsafe? What is causing the instability or insecurity for your housing and neighborhood? Will this community help me thrive? Is there firearm violence happening every day outside your home? And we love the saying of safe space. And you come into mental health like, this is a safe space. We're sending you now home for the other 23 hours of your day where you can be shot in a drive-by shooting at any time. Your life is not safe. So us creating safe space for that hour is important, but us recognizing that the neighborhood you're going back to has probably a broader influence in the conversation I will ever have with you. And we want to make sure that that is safe space. And this creates a deeper level of safety that allows you to go back to that space and thrive in a way you weren't before. So now that we understand the domains of housing, what happens when it doesn't work? What happens when things break down? What is the ramification of this issue? We see on the left physical health. I'm not going to go through all of the bullets, and these slides will be available for all of you to look at in detail. But we're looking at, we have a higher incidence of preterm birth and lack of first trimester prenatal care. We're setting people up from the very beginning before they even have the opportunity to take the first breath on their own. They're starting from behind because of the realities and social changes that have caused their parents to not be able to give them the best. Looking in mental health, we talked about firearm violence and thinking about ACEs, adverse childhood experiences, phenomenal study. And it talks about how the compounding of trauma and neglect really pushes people to have worse health outcomes. 4 ACEs changes your rate of stroke, heart attack, suicide, depression, anxiety, and your opportunity to succeed in getting a college or high school degree, and your ability to make money as an adult. 4 things that happen before the age of 18. This is where mental health comes in conjunction with the physical health. Wealth and opportunity. If anyone is in economics or loves it, Dr. Chetty, coming out of MIT, is producing phenomenal work. Phenomenal work about how wealth and opportunity are different in neighborhoods and what this looks like longitudinally. And then in environmental health, we have a Center for Environmental Health here. It's not a lot of people who are thinking about that. But things about environmental health that we don't often think about is the density of liquor stores and tobacco retailers. How does that play into it? Why is it hotter in inner city neighborhoods and red line neighborhoods than it is in others? How does that impact? We are up in the northeast, the northeast in New England. As someone who moved from Florida, I considered food, water, and central air. Those are the life necessities. Food, water, central air. I got to Boston and I had a realtor. She's like, and this apartment has central air. And I was like, obviously. I paid $600 for the house that I had in laundry, had a backyard and central air. And I quickly realized central air is not in all apartments. And I was bewildered. I was like, food, water, central air. When people are like, look at the crazy things people are doing after a hurricane, it is because we have no air conditioning. That is the main reason things go wild. We have no air conditioning, thus we lose our minds here in Florida. We're fine without the power. The Wi-Fi, negligible. The lack of air conditioning, that's what causes fights. And so when we have higher heat, when we have no heat, those are things that change people's life, not just on the first world issue of my comfort, which I deeply appreciate, not sweaty at home, but on the real reality of elderly die more often in inner city neighborhoods where their homes are too hot and they don't have mobility. Children freeze. I say that again, children freeze in 2024 because they have no heat. I've had patients come in and say our heat wasn't working, and you have multiple children under one bed or sleeping with parents, create body heat inside of a house. This is what our work means. This is why our work matters, because we shouldn't be having this conversation at this year in a country like this. So let's take you to Boston, where I'm from. And so I'm going to use my cursor here. And this little spot where the blue dot is covering is where Boston Medical Center is. That is my home institution. It is the institution I love. The Boston Medical Center was called Boston City Hospital. It was the hospital for the people of Boston. As you saw, that little blue dot is in between white and red. We never talk about white on redlining maps. And the reason we don't is because people were not supposed to live there. It is an industrial zone that was never meant for inhabitation. The hospital I love was placed between red and white, where people didn't belong and where the disvalued were placed. And I love that. That's our story, because that is the work we do, and that is the person I am becoming, because these are the people who are teaching me. For those of you who are in the medical school and you're going to see some of curriculum changes, I'm going to be the first to say, jump into the moment with the community. Be taught by the grandpas. They know more than you because they've lived 3 of your lives, 1. 2, their understanding of the reality that brought them there will change what kind of provider you will be. And you will be a better doctor because of Mrs. Jones, just as much as you will because of your faculty. Take both of that weight together. And I bring this map up to show you. I want you to take a look at the left, and you take a look at the right. The right of the dots is the most recent census tract. Brown is white population. Yellow and green is Black and brown Latina populations there. Let's look at where it's a zoomed in version. So focus in onto the top left half of the photo on the right. The pattern hasn't changed from 1926 to 2020. The pattern hasn't changed. This is the same for you as it is for us. How are we still in the same place? How do we change this? So let us keep going and think about the ramifications. Housing disparities and rent burden. We're going to look at these maps of Boston. So we look at health, we look at our 30% more of household income on the left, darker colors are showing greater rent burden. You're like, what's wrong with the three at the top? Those are student housing. That is Alston and Brighton. That's where all the students at BU live. Thus, they have no income. Thus, their rent is their whole income. So we're going to neglect those. The other darker colors are people who actually live in Boston full time and not 9 months out of the year. And we're going to look to the right and say, those are the demographics of what is the racial composite of those neighborhoods. Predominantly Black and Latina residents are there in orange and yellow. It's equivalent to the neighborhoods where people are not students and are severely rent burdened. Let's run this forward and look at unemployment and COVID. This is a very clear and stark example of those who could not afford to have jobs that provided work at home options. Those who became unemployed because they couldn't go into work are also the places where we have the highest rate of COVID. And you'll see soon also the highest rate of death. Next, we're gonna look at disparities of health. BMC is our lovely little star in the middle, and we look at our neighborhoods who we serve. We are the largest safety net hospital in New England. Majority of our patients do not speak English as their first language or English at all. If we look at where their diabetes rates are compared to the other neighborhoods, you can see there's a drastic difference, not just for the neighborhoods of Boston, but specifically look at Boston overall. Dorchester is between 10 and 12%. Roxbury, the historically Black community and former city, is at 14%. Mattapan, historically and predominantly Haitian American community right now, is at 17.9. Firearm homicide. Roxbury, 7.3 shootings compared to the overall Boston average of 3.8. Alston and Brighton, 0.8, because all of these kids are going to private school and they don't have time. So there's differences in the locations of the neighborhoods. But also you see Back Bay, insufficient sample size. That is a whole neighborhood full of people. They have an insufficient sample size. That is a green and blue neighborhood that has remained and stays. 1,000 square feet, less, actually 700 square feet in that neighborhood costs you over $1 million. Never think your rent is high. As someone who's paying out of her ears, never think your rent is high. That is what's happening there. They have an insufficient sample size shootings. So where do we go from here? This is our outcomes in COVID. These are the leading causes of death in 2020. Let's look across the top. For Asian Americans, Black Americans, Latina Americans, COVID is what killed them. Remember the neighborhoods we looked at of unemployment and rates of COVID? For white Americans, it's cancer. They're in the blue and green neighborhoods where there's not enough shootings and they weren't unemployed because they're working from home and staying safe. Death changes. Life opportunity changes. See, now we're looking at the environmental health. Let's look at the pumpkins. We love them. How are the pumpkins? How are they doing? So we're going to look on the far left. That is your A-rated neighborhoods, our blue and green rated neighborhoods. And let's think about, do they have very low opportunity? It's not even on there. The kids in the blue-green have all the opportunity in the world. You go all the way to the second to last column, that's D-rated neighborhoods, hazardous, Black and brown communities. We have predominantly very low opportunity. This is from the womb. A fact that I want to give you that is an unfortunate fact about medicine and law is we have these things called accidental death or wrongful death outcomes. You've probably heard about them. Someone gets hit by a truck, they sue the person who was not just driving the truck, but the company to say, this person has wrongfully died. Our family deserves financial compensation for the death. It doesn't fix the loss, but it helps the family. The way those are calculated are based on economics they're called blended or unblended tables. Majority, almost all jurisdictions in the United States use unblended tables. And what that means is they stratify and they say, white man across America, what is his most likely outcome of total earnings in his life? We have a 15-year-old who dies. The average lifespan in the US is this. This is the percentage that was lost by this family on the wrongful death of this individual. This is how much money they make. Black woman, you run it across. Black man, you run it across. White woman, you run it across. They have it predominantly for white and non-white, but you can get, depending on where you are, into other ethnicities. So we're gonna make me like super cute and two. And we're gonna take Mike here, Dr. Lamb, and make him also two. You're just like crushing it in our little daycare together, playing, learning how to share. This is what we're doing. Both baby Mike and baby Kayleese are killed by a FedEx truck that goes through a community. Baby Mike's family will get at least double the amount of money my family will get because life is valued more and seen as more valuable for the wrongful death for both too. My parents could both have doctorates, and we can say that Baby Mike's parents, neither of them have graduated from high school, and the likelihood that Baby Mike is going to go get a doctorate from parents who've never graduated from high school is much lower than me if I have 2 doctorate parents. Mike will still get more money because his life is valued more. How does this play into something? Amazon, FedEx, multiple shipping companies drive through Black and brown neighborhoods because they know the payout will be less than driving through white neighborhoods where the payout will be more. This is the opportunity index. From the womb, children are not given the same opportunities or seen as equally valuable because of the structures we have created and because of the reality of those moving forward into time. The last thing, and I think the most sober thing, is this: life expectancy disparities. I did this on Google Maps, and there's some phenomenal research on how to talk to anyone about on how you can do life expectancy differences. The place I placed for green as our top location is a park in Beacon Hill. It was right by that Back Bay area that had insufficient firearm violence. Less than 3 miles away at another park in Roxbury is where I did the differential. We have lost 5 years of life 3 miles apart. 5 years of life 3 miles apart on average. That is excluding the people who have died from COVID early. That's excluding the firearm violence. That's including what that person's life looks like at 80 compared to the very well retired, half the time up in Maine or on the vineyard life of the person in that section who has 2 homes. It's a very different conversation. And I think this is the big question. How do we make sure that people who are 3 miles apart, both born and raised in the same city their entire life, aren't dying at different times and expected to die at different times because of where they grew up? So, where do we go from here? What do we do? These are tiers of advocacy. This is where you all come in. This is the opportunity we have to change something. These are the 4 levels of advocacy: policy, anchor institution or collaborative, organizational or department, and direct support. Some of the residents from PEDS may be here and you're like, these were not our terms. And that's because our terms were special for us. And this is thinking about more on a structural level and purely for housing. I'm going to go through each of these and show you opportunities and things that are happening in ways we can engage to, one, remind you your work matters and it's doing good work, and also inspire you to say there's more to be done and we all have more power to offer. Let's start at the base in direct support. What this looks like is as clinician to patient or provider, community provider to client. What can you do? You can identify and screen. You can support immediate needs, establish a foundation of trust. That is so necessary. It's such important work because it fuels and informs everything that happens above you. So let's go to organizational and department. We're looking at integrating referral services into a general encounter, embedding interprofessional staff, connecting to asset building or advancement organizations. How do we move forward? How do you make sure you are getting the support you need that I, as a clinician, am not trained and unfortunately do not have time to give you, even if I had the training to offer? Let's think about anchor institutions. This is our big UB. What can you all do here? How can we push to get there? Investment in place-based initiatives, invest in community hiring and procurement, engage in power sharing grants. I'll circle back to that because I think that is so important, not just for the outcome, but for the restoration of dignity and the killing of the savior mentality of the people who are academic and smart to go save the people in the community. That is a different thing. In policy, what are the upstream drivers of structural racism and capitalism, and how does investment change and give people more agency? I'm going to speed through this because I'm also looking at the time and recognizing you should hear from Dr. Taylor. And so we're going to move a little quickly, but I'll be here all day if we want to talk in depth. Direct support organization and department. These are things that are happening at Boston Medical Center. So on the left, this is what we call our Thrive Screener. Our Thrive Screener is we're asking you in every encounter, majority of times when you first come in, to say, what else do you need? Are you insecure about housing and shelter, food, paying for medicine, transportation, utilities, daycare, care for elders, job search and training, education? This has been implemented into Epic. So we can click through to make sure we know this mom has just got here and she wants a job and she doesn't know how to find one. We can connect you to someone who can help you with that. This informs our work. street cred. For any resident, I love residents, who is like, I don't know if I can do this. Street cred is created by a resident. Dr. Lucy Marcel no longer practices medicine because she's been headhunted to Washington, D.C. to create financial opportunities as a pediatrician. What street cred is an organization that sits within pediatrics where we do taxes. We help all families do their taxes. And we become tax preparers as people part of the pediatrics department. And we do their taxes because when families go to get their taxes done, they are gouged and lose half of their returns. And they don't know what they need. And we ensure their child income tax credit is provided. Millions of dollars have gone back to these families. And they do it when they come for their well child visit. They come to the pediatrician and we move to the side and we do this. Started by a resident, now a national organization, changing lives. MLPB, Medical Legal Partnership, they advance justice. They are the people who, when you're saying, I still have black mold and nothing has been done, they write a strongly worded letter that somehow gets the mold taken care of. They are given a referral from us as doctors to them. This is how we work on the screening level. This is what everyone can do on that inpatient, in-client encounter, is create these opportunities to move forward. Anchor institution collaboratives. At BMC, we have housing prescriptions. You can get a prescription for housing. We're recognizing this family, we have a munchkin with asthma that is flaring. We're pushing through all sorts of meds. Why are we doing this? Because there's black mold and pests, and they cannot be safe. And why are they back in the ED again? We're giving you a prescription for housing. This is partnered with the Boston Housing Authority, Project Hope, Nuestra, which is a phenomenal Latin-based organization that talks about wealth building, make sure people have savings accounts, knows how to budget. And our medical legal partnership, and there's a section of housing that is known to be connected to the hospital that we can get our kids into places where they need to be safe. On the other side is Nubian Markets. This is something that's new and fabulous. It's just happened at BMC. And Nubian Markets is based in Roxbury. As you've heard that name, A Bundle Now is the Black community, formerly Red Line community in Boston. Today, in the year of 2023 and 2024, when this happened, Nubian Markets was a Black-owned grocery store, could not get financing to build a grocery store in Roxbury. There is only one grocery store in Roxbury. They could not get the financing because it was too much of a financial risk. The hospital lent them $1 million with no interest loan. We are their lenders because we understand that the health and the vegetables and the diet of our patients matters. And we also understand we don't want people eating things that are not in culture and aligned. So they have a full halal butcher. This is about the African diaspora. This is something that's so community-based. It's something that's proud of and owned by their own, and the hospital is their lender. We have the opportunity at places like this to do that for your communities. How can we create the partnerships that are here in this room to make that a reality? Policy and government partnerships. So this is Children's Health Watch. If there are researchers in the room and you're thinking, I want to figure out policy, look for Children's Health Watch. They do national-based policy. They have ED surveys that are in pediatric EDs that ask questions about maternal health, maternal mental health, child health, and outcome. They do all of these things, and then they push it into national policy briefs, and they move it forward in Washington. This is one of their policy briefs that I don't have to worry talking about how things of the child tax credit helps families pay for rent. They're a major force both in Massachusetts, but nationally creating opportunities. This was created by pediatricians who said, I don't understand why my babies don't have food. And so they said, we need numbers to get money because they're not going to believe my testimony without the backing. And they created this, and it's become a national network at multiple hospitals around the country that are pooling numbers and making broad scale policy change. On the right is Chipchana. This is something for Boston. And if there are any city officials, people who know city officials, show them this and tell them that you all can do this here too. So Chipchana is something that is based out of the city of Boston. It works with the mayor's office, our Boston Department for Public Health. It is a perk that Boston is also the capital of the state, because the state house is right there, so it's just easier to get things done. We partner with every single large hospital institution as part of this. Over $10 million has gone to housing, just housing. This addresses housing, wealth disparities, mental health, safety. All of those 4 pillars are the different organizations, and in a place that is hyper-competitive, not in the athletic sense, but in the academic sense, which is Boston. No one's going there quite for college football, but we go there to get a college degree. They are very pretentious about the people they are helping, and they don't like to share often. And this is something that has gotten everyone to the table to say, if we can get a partnership and have the catchment of Brigham and Women's match with BMC, we can actually make sure more children are born healthy. This is what deep partnership looks like, and it causes an opportunity for reduced housing insecurity and homeless, and supporting the efforts of increased pathways to stabilization and home ownership. These are just two of the three major pillars that they are pushing solely on the housing perspective. I haven't gotten to show you all the other great things. So these are possible. These are happening in hyper complex institutions and cities, in a city whose history and reputation is true and hard. Boston is the place you see when you look at how busing riots for the education of integration. That's in Boston. It is not a place that like kumbaya ever, and is not even figuring it out now. What's happening here, I hear, is a similar history in a lot of ways. It is still possible for us to get together and do good work on behalf of the communities we love and the people we care for. So this is our big circles. Think about where you want to be, what jazzes you. I was talking yesterday, and I don't yell. I just don't. I don't get to anger very quickly. I'm not meant to be out in the streets organizing much of anything. I organize logistics to make sure you don't get arrested and have water. That's my role on a protest. I'm not your direct support person. I'm not. I'm your inside man. I'm your anchor institution collaborative policy person, because a protest without an inside man is just yelling in the street. If you do not have someone who's going to take the important message that you are bringing to forefront, that you're causing peer pressure to come down upon, to translate it into generally like more politically acceptable language, to do the outcome you're really pushing for, you're just yelling. Both are needed. And so where do you want to be? Where you come alive? What does your skill set allow you to do? My skill set allows me to connect and talk like this. I don't yell. I can walk very far distances and I can carry signs, but I don't yell. I'm just not the person you want. And that's all right, because I recognize where I belong, and I trust I will find a partner who is so passionate and empowering that I, even though I was there planning with them, feel re-inspired just by listening to them and watching them create the movement that we are seeing. So I just want to invite all of us to figure out our place in this story. I want to encourage you that this city, though I've only been here for a strong 24 hours, is beautiful. You have good people. I love your people. I've gotten to meet so many of you, and every time I meet a person from this community, I'm like, this is just good energy, good space, true work. And you have now a partner afar who's ready at any point to encourage, provide resources, connect. Because I believe in the work that you're doing and the time you're taking to show up here to have this conversation. So with that, I want to thank you for your attention and pass it on to Dr. Taylor.
Thank you so much, Kayleigh. That was amazing. And for those of us on Zoom and in the audience, I think what we'll do is questions after Dr. Taylor. We'll just do Q&A afterwards. And I do apologize for all the folks who on Zoom may need to leave. I recognize that we're a little over time. For those of us here in person at the conference, we're just going to steal a little bit of time from the poster session. It'll be totally fine. We definitely want to hear from Dr. Taylor as he will give more of that background for the local, while Ms. Green did give a lot of Buffalo context, Dr. Taylor will take an even deeper dive into local neighborhood transformation movement that is taking place. Dr. Taylor is Professor of Urban and Regional Planning at the UB School of Architecture and Associate Director of UB Community Health Equity Research Institute. His research focuses on a historical and contemporary analysis of underdeveloped urban neighborhoods, social isolation, and race and class issues among people of color, especially African Americans and Latinos. He is the founding director of the Center for Urban Studies, which seeks solutions to problems facing metropolitan regions and central cities, including shrinking cities. The center conducts basic and action-based research on community and economic development, focusing on the needs and issues of traditionally marginalized groups. Dr. Taylor coordinates the neighborhood planning and community development specialization and teaches courses in central city revitalization, urban management, and race, class, and gender in the city. Dr. Taylor also coordinates the Center for Urban Studies Urban Internship Program and creates opportunities for graduate and undergraduate students to become involved in neighborhood redevelopment initiatives and in research projects. And I could go on and on. He's just done so many remarkable things, not even just in the housing space. So, but without further ado, Dr. Taylor, please, thank you for joining us.
I get it. Thank you very much. Can everybody hear me?
Yes.
It's a pleasure to be here with you this morning. I've scripted my presentation. As a university professor, my lectures are usually 3 hours, and I don't even know how to say hello in 5 to 10 minutes. So if I don't write things down, we'll be here until this time tomorrow, and I'm sure you have some other things you want to do before midnight. My presentation focuses on how we solve the housing problem on Buffalo's east side. And it will center around an overview of a neighborhood development project that we're in the process of initiating. K.L.E. Green has talked about and given us great insights into the issue of housing conditions and their relationship to adverse health outcomes in the Black community. Most significantly, within this context, it is important to understand that housing and neighborhoods in an urban context are inseparable. They are fused together. Therefore, I contend that rental housing conditions, along with the negative social determinants, play a critical role in the underdevelopment of Black neighborhoods. Therefore, you cannot abolish race-based health inequities without radically transforming underdeveloped neighborhoods where Black people live. Black neighborhoods matter. Now, for more than 3 decades, health scientists and the medical professions have tried to improve health outcomes among Blacks without transforming their underdeveloped neighborhoods. They failed. They failed. Now, let me be more specific. Since the 1985 publication of the Heckler Report on Black and Minority Health by the Secretary of Health and Human Services, the United States has spent millions on health equity research. Scholars have published thousands of research studies, and practitioners has initiated numerous projects, programs, and activities in communities across the nation. Yet, despite this incredible effort, no meaningful changes in the health outcomes of Black folks have taken place. I'm talking about here as I stand, we have infant mortality rates at third world levels. As I stand, premature death making is rampant. As we sit here, low birth rate births are at third world levels. This failure provides ample proof that underdeveloped neighborhoods must be radically transformed to eliminate race-based health inequities. This viewpoint is informed by extensive research on the causal link between social determinants and adverse health outcomes. And adverse health outcomes in the African American community. Consequently, the key to the abolition of race-based health inequities is the transformation of underdeveloped Black neighborhoods into great places to live, work, play, and raise families. This complex and challenging task will require the creation of a model of neighborhood development that contests the traditional white neighborhood model. The traditional white neighborhood model does not work for Blacks because it is based on exclusion, homogeneity, segregation, and the use of owner-occupied house as a tool of individual wealth accumulation. Such a neighborhood model is designed to bolster housing values, accumulate wealth, generate power, perpetuate privilege, and convert the racial hierarchy into a neighborhood hierarchy, with white neighborhoods at the top and underdeveloped Black neighborhoods at the bottom. These underdeveloped neighborhoods, in turn, are designed, intentionally designed to reproduce Blacks as low-wage laborers or prison laborers. Since Blacks cannot use this traditional hierarchical white neighborhood model, we have developed an alternative people-centered model. This new approach aims to enhance African American social, physical, and mental well-being and ensure the community's long-term sustainability. This people-centered model prioritizes the residents' needs, aspirations, and participation in the neighborhood development process, and it comprehensively addresses the root problems confronting Blacks holistically rather than in a haphazard, piecemeal fashion. This people-centered model is grounded in 7 core values drawn from the history and lived experiences of African Americans. These values include solidarity, participatory democracy, community control, inclusion and belonging, shared ownership, cooperative economics, and community wealth building. Residents will use these principles to reimagine, and guide the neighborhood planning, design, and community development process. Now, time constraints, that is, unless you want me to talk for another 3 hours, and I can do that, I will prevent a detailed discussion of these 7 core values. However, before moving on, I want to briefly address the importance of one core value, community control, and the significance of Blacks gaining agency over the neighborhood territory. Blacks do not own or control the land on which their community is built. This reality results in outsiders making key decisions about land use, property value, development, real estate, and vacant lot management. Simply put, people living outside the neighborhood have the authority and power to do whatever they desire inside the neighborhood, regardless of what the residents think, need, or desire. This lack of control is unacceptable and must be stopped. To address this issue, we plan to implement two interrelated strategies. The first is to establish a neighborhood council that will democratically govern the community. The second strategy is to establish a community land trust to acquire residential and commercial property in the neighborhood. Together, these activities will empower the residents and significantly enhance their influence over the neighborhood's development process. So, the big question is, how can we use these core values to transform Buffalo's East Side? First, we intend to create a pilot project in one neighborhood to determine the viability of the concept and then apply that successful model across the East Side, but also across the city and the metropolitan region. We must alter this hierarchical, exclusionary, and racist model of neighborhood development, not just on Buffalo's East Side, but across all communities. Second, we will establish a neighborhood planning and design and community development center to oversee the community development process. And third, we will work with residents to develop a shared vision of the type of community they seek to build. This shared vision will unite the community and serve as a cornerstone for all planning and development decisions and activities. Then, using this shared vision and the core values as a GPS system, we will establish a comprehensive planning process based on community organizing, maximum resident participation, targeted universalism, control of market dynamics, and simultaneous planning and development. Within this context, there are two critical aspects of our work that need to be mentioned before I close. The first, we must control market forces. They pose a significant challenge to the progressive development of the pilot neighborhood. As the community becomes more desirable, politicians, developers, and land speculators will seek to dominate the neighborhood development process, hoping to increase property values and rents, thereby altering the neighborhood's character and displacing its residents. We intend to keep this from happening. By prioritizing the control of market dynamics, the neighborhood will be able to guard against gentrification and ensure that development benefits all residents, not just a few investors and outside interests. Second, community organizing will be the animating force driving this neighborhood transformation process. From the beginning, full-time organizers will be in the streets, educating, engaging, and empowering the residents, encouraging them to participate and take ownership of the neighborhood transformation process. The aim is to turn the neighborhood into a sophisticated community organization, united by a shared vision and propelled by the residents' willingness to fight. And that's what they will have to do for the policies and the resources required to transform their neighborhoods into a great place to live, work, play, and raise a family. In closing, right now we're in the process of selecting a site for the demonstration project. We have narrowed the search to 5 East Side census tracts and will officially announce the site of the project in late June. There's one final note that I want to make. In the book, Black Power by Kwame Ture, formerly known as Stokely Carmichael, and Charles B. Hamilton, they emphasize the importance and the significance of placing and grounding the efforts to address the challenges facing Black communities in reality, not in fantasy. I'll put this down to close. In all of our work and in all of our efforts are often grounded in our fantasies about where we are and what we want to happen based on a fantasized story of American society. When we look at the truth and ground our strategies in that, we have a hope for bringing about change. When you understand, as Kaolis points it out, in the way these neighborhoods were created, to profit make, race make, and place make. We can't follow that path to create a better world. We've tried that for 200 years. We have known for centuries that a relationship exists between where people live and their health outcomes. This isn't new. They were talking about that in the 1800s. But we did nothing about it. Why? Profit making. That lovely white neighborhood requires the East Side. That's where values are associated. So we can either continue to move on the basis of fantasy, and they're wonderful stories. There's stories about Black people will own homes. They will make money from the selling of those homes. They will pass down generational wealth. We just got to get them to own more homes. That's a wonderful story. But in these 5 neighborhoods that I showed you, in all 5 of them, the homeownership rates are close to 50%. In one neighborhood in the Broadway Fillmore area, 69% of Black people own the home in which they live. And in that census tract, those houses are valued at the median level at $38,000. If I put a 10% down payment on a $400,000 house, I could have bought half the houses in that neighborhood and paid cash for them. We must move from fantasy to reality. And when we do that, we can change the world, create a better society, and abolish these race, place, health, and equities. Now you know why I have to have a script. Thank you.
Okay, stay up here, Dr. Taylor, and Ms. Green, if you want to come up too. I don't want to take too much time because I do want to give the residents a chance to present their wonderful poster projects, but I do want to give some time for questions. So if we want to just start, are there any questions on Zoom? No Zoom questions. Okay, anybody in the audience with questions?
Hey, I just want to say thank you both. These were both so informative. And my question is, how were these specific neighborhoods being identified on the east side?
That's a great question. We've gone through a fairly extensive process. There's some 32 neighborhoods on Buffalo's east side if you use the census tract as a neighborhood, and we use the census tract as a surrogate for the neighborhoods. We developed a hardship index based on some 9 to 10 variables to measure the levels of hardship that was found in each of the census tracts. Then on the basis of that, we looked at the geographic locations of those particular sites and looked at things like proximity to what we call the gentrification threat zones. And we selected 4 tracts. And then we opened up to our administrative team. This project is overseen by a team of about 18 people, representative of a number of different groups, both city, county government, as well as some other organizations, with our main partners being Back to Basics, the Buffalo Center for Health Equity, the African American Health Equity Task Force, the UB Center for Community Health Equity Research Center, and the Partnership for Public Goods. And out of that process, 1 neighborhood was nominated, and then we came up with that 5. And now we're doing additional research in those 5. We've already conducted some 565 house-to-house surveys in each of the different neighborhoods, done physical analyses of each of the neighborhoods, and done detailed demographic analysis. And on the basis of that, we're now in the process of analyzing the data. And then on the basis of the data, we'll create 5 profiles and start to get inputs from residents and input from others about which of those 5 they should select. And in the end, on the basis of that information, the admin team will vote on what they think would be the site for the demonstration project. And again, let me just say, we wanted to do it this way because we knew everybody would have their favorite neighborhood. And we knew that all neighborhoods needed to be developed. And we also wanted to begin to demonstrate that we ought to follow some type of process that's objective and scientific in making choices and decisions, and not just arbitrarily deciding on this and that. And so that was another reason we decided on the particular approach.
Hi, thank you so much. Today has just been so moving and it's amazing. So thank you very much. I just wanted to dig into that community participation because I work at Buffalo Go Green and I want to be able to assist in any way. How can we get that buy-in? Is there money being, put forth for the community's time? Like, how are we going to organize that way?
That's a great question again. One of the reasons that we're hiring organizers is that we think that the process of building a shared vision will probably take close to a year. Your organizers are your key. I mean, you got to go house to house, street corners, bars, places where even the angels dare not tread. Uh, seriously, you got to talk to outlaws, all of the elements. And those have to be a lot of one-on-one conversations with people. It has to be small focus groups and ultimately culminating in a big visioning process. But you have to go where people are and not get caught up into the fantasy. You can have public meetings and you're going to get all of that. So it will take time. People are angry, people who are mad. But as you begin to talk to people, they will begin to realize that the values that we're talking about flow from their lived experience. There was a reason that we put those pictures up with the Sankofa bird that looks backwards in order to understand our history and gain lessons to guide us into the future. So we will institutionalize community organizing. In most organizations and groups, probably all of your own, there is no one on the staff whose job is organizing. We stopped doing that. So we're going back to the future. We will put at the forefront community organizing, and through that process, we will build those levels of unity. But make no mistakes about it. It will be time consuming, and it will require multiple conversations at all levels. But at the end of the day, you unify the community, you change the world.
Okay, we have a couple questions on Zoom. The first being, how does the medical center work with the housing authority? PBV or HCV?
Say that again.
How does the medical center work with the housing authority? PBV or HCV?
I don't know what PBV or HBV, and I'm not sure about the housing authority. I'm very disappointed in our housing authority, but that's a whole nother subject. But I think that ultimately you got to work with the city and all of these groups, because that requires the building and construction of new housing. You'll hear about this later today. We've got to get existing laws enforced. These houses are killing people. And when we talk about new builds, and especially infill housing, and I'm a proponent of that because they are important and new construction is important. But people are dying and being destroyed in the current housing in which they live. That was what Kay Elise was talking about. These houses are killing people. So you can't ask people, you cannot turn substandard housing into a sacrifice zone. You can't do that, where you're asking people to sacrifice their lives and well-being until you can build enough new housing for people to come into. People make a mistake by concentrating only on affordability. She was saying that it's not just affordability, the housing is killing people. That's what we have to grasp. And if we understand that this housing is killing people, our first step, fix the housing where people are living, then build something new.
Just slightly add to that question around hospitals and housing here to add to Dr. Taylor, and it comes back to the question of vision. Just as you're saying, is there someone on the staff whose role is to community organize? Does the hospital have a vision to invest in housing? And have they tasked the government affairs team to represent the goals of the hospital with the with the Buffalo Housing Authority? Is their vision to create partnership? Because it has not been tasked and there is not investment on the hospital side, financially, time-based, organizational. I think all of that goes before the conversation for that partnership to be created. And from the Boston side, it was a priority for our government affairs locally, both at the state and city level, to build the partnership with Boston Housing Authority over time to make sure this was a reality and there could be an opportunity for housing prescriptions. So I think vision and the clarity of that on both sides is really what allows us to build forward innovative partnerships.
Some of you might remember a number of years ago, a general hospital under John Friedlander's, the late John Friedlander's leadership, had proposed what he called at that moment in time the Vision 2020 plan. And it was an effort on the part of General Hospital and others to completely transform and rebuild and develop this entire area for the people who lived here. Unfortunately, with the rise of Collider Health that just ate up all of these groups, you know, the Vision 2020 plan became very different, and they can't plan on doing something else. So those layers and levels of partnership are possible.
Hi, okay. So I really appreciate the tiered level of intervention, that there's kind of a multi-stage approach to this, but I think coming from academia, research, funding, implementation, there's this concept that if things are not going to be like completely successful, they kind of like fall to the priority list. And I guess I'm wondering there's a sense of urgency to this topic. So it's like, what are the things that should be done first, I guess? And what's the best way to accomplish them? And if there have been kind of successful interventions that have gained buy-in, or stakeholders saying, you know what, this might not be as successful as something like vaccine rates that are really easy to track and really easy to implement. This is a really complex problem. So I guess I'm wondering, what are successful things that can be, you know, done relatively quickly?
Well, the first thing I want to emphasize is the importance of a comprehensive approach, the importance of neighborhood planning and development, and the necessity of seeing that all of these problems, there are many issues, but they're all interrelated and connected, with each one reinforcing the other. So you have to operate within a neighborhood context. I mean, I think that's extremely important. And there's enough that we've learned from the past to say you got to build a model and then implement that model across the board. So, you know, within that context, we've established what we would consider our 4 or 5 top priorities, which means that these are the things that we suspect will evolve from the shared visioning and planning process. But we think at the top of the list is fixing the substandard housing. We think that's extremely important and critical. We think youth development is also hugely important. And on the educational front, we think reading is the key. And that's an area that we're going to be emphasizing. Most significant is the question of on-the-job training. And I really want to emphasize that. If you rebuild and develop the East Side, you will have to spend millions and millions of dollars to do that. And so the question we raise, where will that money go to sleep at night? And that's my way of saying, who will get the jobs and the opportunities? And the idea is to create the job training programs that allow East Side residents to do work designed to fix their neighborhoods and communities. And we don't do that. We don't do that. The mayor just announced some $140 million more dollars coming into the city. Most Black people aren't going to get those jobs. The billions of dollars being spent to cover the Kensington Parkway. Black people will get the bridge, but they're popping champagne and smoking cigars out in Amherst because they will get the contracts and the other things. They built this thing. Black people didn't participate in this. And so what we're saying is that at the top of the list, we know construction is coming down the line. So we train folks to do that work. We train folks to build the houses, like all this new infill house. Who's gonna build it? The money we use in the development of our community must go to sleep at night inside of these neighborhoods and communities. So the on-the-job training becomes a huge issue. And then health as a real target and focus. And in our world, health outcomes, become the most important. But in setting up the project, you want to have people working on all these things. You got a team that's doing your social service work. You got a team that's doing housing and neighborhood development. You've got another team that's working on health, but all integrated, connected, and administered in this kind of way. And you're constantly listening to the people down on the ground. And this is why we will keep saying we're building a new model and approach. And we've learned from the past. If you look at the history of Build organization and really study the history of Build organization in this city, you will learn a lot from an effort that was made a number of years ago to comprehensively develop the entire East Side. And when we learn from those lessons, allow us to say, let's focus on a specific geography. Master the process of development in that geography. And then once we do that, we begin to spread that map, that strategy all over the city. Since we're in the medical building, imagine a virus that gets generated. And imagine that virus operating as a bacteriophage, moving into these underdeveloped or moving into hierarchical communities, transforming and changing it into something else. So it's identifying the priorities, creating an integrated approach to attack them, while at the same time operating all of that within the context of what we call targeted universalism. In other words, by way of an example, we want everybody to read, but we know everybody is at a different level, so that we want to work with each individual based on where they are to get them to where everybody needs to be. And that's what we mean by targeted universalism.
Add one other component to everything that Dr. Taylor has said. There is a concept that, especially when you are thinking, I care deeply about this thing, but in the context, I'm not sure what department you're in, this is not what we care about on the department level, and you don't have the power as of the moment to set the priority. Interest convergence, Derek Bell has been the person who's created that thought process, and something that all of us need to use if we are not the people who set the vision. And so I'm in the process of getting ready to publish a paper that I'm doing around firearm violence, homicide rates, and it's looking at predatory inclusion and high-risk loans. The person who is my co-author is a trauma surgeon. Trauma surgeons are not concerned about housing. They're concerned about the firearm violence that comes into their ORs. So by having it be a firearms paper that uplifts the reality of housing on where firearm is happening, we accomplish our goal of bringing light to the reality, but also interest convergence, meeting the goal of the trauma department to say we care about firearms because that's our work. So wherever you are, it's figuring out where does your interest and passion around social justice lie, and where's the interest conversion of the people who have power in the small p power of your department and who's going to let you do the project or give you funding, and the big P power of is it going to get funding? So if we think NIH funding and they're like, we don't care about this, which is many of the important things. How do you figure out what they care about and who has done it? Someone has done what you want to do incredibly well and has baseline data. I would be bewildered if I couldn't find you a person. So what, if we're going to think about housing, and do you mind telling, what department are you in or research are you thinking about? Okay, yeah. And yes, what area of study and research are you coming at it from? A virology point of view, from a, where are you? Yeah. I would say for you, if we're looking for little P power and big P power, the Robert Wood Johnson Foundation is your people. They are your people. They already believe you. They have the data. The NIH respects them and creates fellowship. It's in their name. Find a way to be a part of that, to connect yourself to the people who've done the thing and who have now the clout to create their own vision, that have proven the data to get you to the place where you want to go. So how can we interest converge in Rochester for the little P power who's saying like, that's not our research, but say they're like, we really care about maternal health. And let's figure out where these babies are eating lead and changing things. You can still do your work, but you have to find a way that they feel like they're winning. Someone yesterday said, are you tricking them? Yes, that is what we are doing. We are moving strategically to get done the good work that needs to be done. So I hope that's helpful.
Hi. So first of all, thank you for coming to speak to us and teach us about all of this. It's very much appreciated. So I actually have a question for Kay-Elise. It's more of a request, actually, because of what you mentioned with the hospital in Boston, lending its support financially, especially towards that supermarket, the Black-owned supermarket. So we have similar issues. We have food apartheid issues here. It's very prevalent, especially since we're coming up on the 2-year anniversary of 514. So what resources can you suggest to us, what you can speak to me after, or in general to us, on how we can leverage support from UB to not only address food apartheid issues, but housing issues? As someone who works in housing, there's several projects that I'm working on, and we're trying to find a way on how to do exactly what Dr. Taylor mentioned of controlling market resources, because that seems to be a really huge issue here in Buffalo with a lot of developers taking advantage of aging generations on the east side, taking their homes, or everywhere really, and monopolizing the rent market. So what suggestions or what resource can you share with us so we can then tap into what Boston did and hopefully bring that success over here?
Absolutely. Yeah, that's a fantastic question. And I think I'm going to talk broadly, and I'd love to talk to you in depth about the nitty gritty afterwards. But it comes to vision and priorities. I don't know UB in the sense of I can't say that the hospital has decided that food insecurity, nutrition, or housing are their priorities. And if they don't have this as the priority, I can't give you any advice for a partnership. Dr. James, who you've heard some quotes from, she's the vice president of mission. That's her role, of mission. She makes sure we stay aligned to our focus. And thus, when the hospital has built the priority that we believe we need wealth investment, and they have been able to secure through large-scale JP Morgan Chase grants that are coming in, be able to pull it that way through our philanthropy, but saying this is our priority, it gives us the ability to spend the money, make the partnerships with Boston Housing Authority, make the partnerships with, we've had the Children's Health Watch who Joanna's nutrition organization in 1992. So 31 years, 32 years of data specifically looking at that, that's now become a national organization. So when they did renovations on the hospital, we have a garden that sits on top of the hospital to bring in produce. We have a demonstration kitchen to teach patients. We have food prescriptions. I've had many patients who are like, I have a prescription to go to a food pantry, and they can get that day of and go and receive food. But that is a hospital priority that's allowed for innovative partnerships. And since I don't know this community, or Dr. Taylor does, or know the priorities of the hospital, I can't tell you how to partner if they don't care, for less of a better term. Like, if that's where they've not valued it, where can you find, as to the prior question, interest convergence that allows them to do whatever they prioritize as their community mission to allow you to do the important and necessary work, but also get the funding and buy-in from the larger power structures here. But keep them tight. Yes.
Testing. Yes, this is to Dr. Taylor, correct? First of all, I'd like to thank you. This is very informative. To piggyback on the housings are dangerous, do you have a coalition for these new landlords that's buying up this property, that's raising this rent? over thousands of dollars and not putting a new paint on the wall. Most of these houses, as you stated, are full of lead and full of bad water from the lead in the water. So a lot of our children on the east side of, especially the east side, have lead issues that's giving them actual behavior issues. And once they go to the doctor, it's ADHD, OCD, put them on the pill. But no one takes it back to the environmental, to go to the home, to scrape the lead off. So when these landlords come from New York and LA and buy these properties and get them and go from 800 to 1200, is there a correlation to come behind them to see if they're upgrading these houses themselves? Because they're not. They're really just, they're taking advantage of the people in the community by raking these houses to these astronomical prices.
What you have going on in the city is a significant amount of land speculation. People buying up houses and property with the anticipation that development will raise prices, and as a consequence of that, they will be able to make windfall profits. You add that to that the economy of the way these rental houses work. The reason that individuals are able to make a lot of money on these houses is by charging high rents and minimizing the levels of maintenance. And in the neighborhoods that we're talking about now, and these are the hardest hit neighborhoods in the city. In all but one of those 5 neighborhoods, the median gross rent is higher than the median gross rent in the city of Buffalo. And in most of those neighborhoods and communities, people are paying 48 to 50% and more of their income. And to put that into perspective, the median household income for most of these families that are renting is around $21,000 or $22,000, and that's in 2024, money. So it's a serious issues, and people are making a lot of money. A big part of the solution is the city and the county can't get on the same page and just enforce the laws you got. Enforce the laws you got. We're not even talking about new laws. Vigorously enforce the laws you got. If people don't fix up their house, take it away from them. I mean, that's the law. So our mission is to get the city and the county to find a way to work together and quit pointing fingers and solve this problem in this issue, and concentrate on fixing the houses that we got before you start building a lot of new houses. We do not want to continue to use bad housing as a sacrifice zone for Black people. And that's the end of it. Enforce the laws.
Back onto that, back to the research question. If there's someone in here is thinking hematology, behavioral development, pediatrics, neurology, the data is so clear about the impact of that. If you want to do a project that has a social justice aim, look at national levels and what's happening in the East Side, because children on their well child visits all throughout childhood have specific national guidelines to have their blood tested for lead. If we want to bring the city and they're like, this isn't happening, you have the data in the hospital charts. You can run the numbers against the national average. So this is how we use data to bring for a social justice mindset. If this is in your field, it's very easy for hematology, like, we want to do a blood project. They're like, I don't even care what it is. Go for it. But you can tag that here to help your local community, because we already have AAP giving you lead maximums, minimums, what happens, where the neurological development is, and then we can look at how neurological development impacts educational outcomes well. That line is clear, and we can take it from the basic science. If we have an issue that needs evidence, if you need a project throughout all of med school, you can even do retrospective work on this and pull patient charts to make your IRB less of the pain that it will still be, and still help the reality of children who are harmed today. So this is how we can take basic science or any kind of research to further very necessary and important work for the communities that we're in.
Yeah, and then one last thing I just really want to mention. This is something morally wrong if you get in more trouble driving a car with an expired ticket sticker, inspection sticker, than you will for renting a house full of lead. There's something morally wrong with that.
Good morning, Dr. Taylor. I have a question. So I know that you've done a lot of data and research and including a panel discussion on how we transform a Black East Side, but there's another neighborhood that I don't think has gotten enough attention that according to the US Census data is actually holds the highest concentration of poverty, which is actually the Lower West Side. And all three planning neighborhoods of the West Side, when combined, the Upper West Side, the West Side, and the Lower West Side, culminate one of the poorest overall neighborhoods in the city of Buffalo, where the plurality majority constituency is a Hispanic community and a growing and very diverse New American community. We saw recently with 510 Niagara Street recently being demolished due to neglect, as well as continued decrease in quality of life and declining housing stock. Has there ever been considerations for analyzing or gathering data and information on the West Side to properly develop and implement a neighborhood plan?
That's a great question. We're very knowledgeable and understanding of West Side development, and we've done a lot of analytical work. We just haven't written it up on the paper side of it. And so, and we're saying the far West Side because I think that's where the elements are. And so we're more than happy to share our knowledge and understanding of what's going on to our brothers and sisters in that part of the city. And particularly because I think that the frameworks that we're developing for work on the East Side are frameworks that we can utilize to drive development in that particular section. So for us, it was just a question that we were focusing on the East Side because of both a combination of the large numbers of concentration of African Americans in that region. But we also knew that there was now a growing movement of people moving from the West Side into East Side neighborhoods. In fact, some of the poorest now East Side neighborhoods are ones with large Bangladesh and Asian populations in that. So our desire is to work with that community, develop that infrastructure and training so that we would better understand it. And in fact, I spent a good deal of time just in Latin America over the last decade just to develop a deeper understanding of Latino culture and how that works. So we're in communication with them, and my team has been working out just trying to figure out a good schedule to do that. But we think that's an important part of the city, and we think that the magnitude of gentrification is much greater in that section of the city, and those neighborhoods and communities are in much, much greater danger, in immediate danger than they are on the West Side because of the levels of development. So the far West Side is very much on our radar screen, and we're in touch with that neighborhood and community, and are willing to provide them with insights gained from our own experiences and work on the East Side.
Thank you.
Good morning. First, thank you so much for coming from Boston. I love Boston. I love Dorchester. I love Roxbury. I love the Cape Verdean communities over there. Henry, you know I'm not talking to you.
I know we talk enough, Denise.
Yeah. So, but the real is that in getting organizers, I mean, the seasoned organizers like myself, right? You already know, some of us already know, there's not a lot of trust, there's not a lot of faith. And so when you're talking about getting organizers, even in Boston, like I'm familiar, right? So like, how did you gain that trust and be able to bring people in so that they believed that you were actually doing something that was going to benefit those communities?
Absolutely. First, thank you for the question. I think it's threefold. As a seasoned organizer, you know that action speaks louder than talk. That's why you do the work that you do to make sure that action occurs. And I think one of the ways we saw predominantly during COVID that was incredibly successful for making sure that our ethnic communities were, one, able to be vaccinated, willing to be vaccinated, and had access, is we partnered deeply with the religious leaders in the community. The big AME churches that still remained, even if people weren't going to church, they knew Pastor Jones had been there since their grandmother was there, and they trusted them. And so we would go to church and say, like, we are here to partner with the pastor. Would you help us make sure your community is safe? Vaccination sites were often held within Boys and Girls Clubs in churches. They didn't have to come to us. We went to them and we partnered and leveraged the voices that they already trusted because we were foreigners in their space and recognized that. So someone I know, if I was coming to do anything here, they would trust you before they trusted me, reasonably. And so I would come to you and say, would you help us do the good thing we want for this community? But they don't trust us, they trust you. What can we do to provide you the access and the resources that you need for this health outcome? But they need your voice because they're not going to believe us. So that was a lot of what we did, was partnering with a lot of pastors and imams in the neighborhoods to make sure we hosted it there. And they were very much our mouthpiece in that regard. I think the other thing that has made these things successful is there's follow through. It actually happens. And something that I love, and one of my favorite stories about this, is in Boston we have a high Haitian refugee population that are coming in droves right now. That is one of our highest populations who's moving. And we often have a lot of pregnant folks who are coming, late stage pregnancy showing up, either in L&D on the verge to labor, or we're at 30 weeks and they've never had a prenatal visit, and we're doing a whole lot of catch-up work. And we began to ask, why are you coming here? We're seeing it happening, and we're asking colleagues at all the other hospitals, and they're not seeing the numbers we are. We started to ask, why are you coming here? And multiple patients would take out their phone and play this message. In the Haitian refugee pipeline, there is a WhatsApp channel that everyone gets tagged into. And these patients are coming from Haiti to Brazil to somewhere else in Central America to Boston directly. And they played this message for us, and this is an abbreviation of what it says. It says, when you arrive at Boston, go to Boston Medical Center. They will speak your language and care for you. And then they would go on from there and say every name of a Haitian-speaking provider. And this is updated because the message would change, because every new resident who came who was Haitian-American or who spoke Haitian Creole would be added to the list. And so first-year residents who spoke would be added to this list in OB. And so they came to us and they said, our community has told us you're safe. We trust you. And to me, like, as a future provider, that is everything. I get goosebumps every time I tell it, because that's telling me we're doing good work, that when they come, we show up for them and we come through. It doesn't matter what time they come to us. They know they're going to get a car seat. They know that we're going to connect them with WIC. They know that we're going to have an interpreter to speak their language. We're going to get them connected with a birth sister. We are going to look at this baby and talk about their chubby little thighs the same way we would talk about a white baby. We will do everything in our power to make sure that they know we will fight tooth and nail to make sure that person who's birthing and that child survives. And it will not matter at any point they come. We have been committed to our word. And I know you know the value of that commitment. And I don't know how to encourage that here, but that's sort of why they trust us, because we haven't failed them. And that would be my sort of advice. Mm-hmm.
So we should have scheduled an hour for questions. I'm so sorry to those of you who wanted to ask questions. For those of you who are still hanging out on Zoom, I'm so sorry we couldn't get to everyone's questions. They will be here, but I do want to take, what time is it? Okay, we are going to change the agenda slightly here. Okay, so it's a little after 10. So we're going to